We'll move on. One or two of our presentations are pre-recorded, and I'm delighted to announce now that we have some opening remarks from Professor Stefano del Prato from Pisa in Italy. Stefano is the president of the EASD, who's part of this initiative. I am the EASD representative on the program. So if our technical team are ready to show Stefano's remarks, we can go ahead. Thank you.
Hello, my name is Stefano del Prato, and I'm a professor of endocrinology at the University of Pisa in Italy, and the current president of the European Association for the Study of Diabetes. It is my great pleasure and honor today to welcome all of you to this Precision Diabetes Medicine Virtual Meeting 2021. Since the very early version of the ADA-ESD consensus for the management of hyperglycemia and type 2 diabetes, an effort has been paid to highlight the heterogeneity of the disease, a heterogeneity that is now apparent for type 1 diabetes as well, and easily recognized at first sight if the entire spectrum of the disease is considered. Such a heterogeneity calls for a more personalized treatment strategy, one that the 2012 ADA-ESD consensus referred to as a patient-centered approach. Yet the elements the clinician today can use to identify the individual needs of a person with diabetes, though informative they may be, still remain largely imprecise, relying more on the experience and expertise of the physician to decide goals of treatment and selection of therapeutic strategies. Therefore, the risk is still there to turn from what we would like to be a patient-centered approach to what it may remain a doctor-centered approach. More data than the clinical variables may be indeed required for a truly accurate description of the individual features. This may require the use of a new and more sophisticated diagnostic tools. This may require more personal data to be collected to reflect the subject's inclination, habits, education, and so on. These data needed to be integrated with the biological ones in order to capture all different subtypes of diabetes in the attempt to move from personalized to precision diabetes medicine. Now, it was back in 2015 when in his State of the Union address, President Obama stated, "Tonight, I'm launching a new precision medicine initiative to bring us closer to curing diseases like cancer and diabetes." Yes, diabetes. And to give all of us access to the personalized information we need to keep ourselves and our families healthier. Yes, diabetes was already in the agenda for the development of a new era of medicine, a medicine developed through research, technology, and policies that empower patients, researchers, and providers to work together toward development of individualized therapy. An approach that allows tailoring treatment and prevention strategies through genome sequencing, pharmacogenomics, whole different omics, microbiome composition, as well as data collected day by day by the healthcare providers and patients. This, as you can understand, is not a simple process. It requires a lot of elaboration and a lot of data. In a survey performed a couple of years ago, more than 14 programs for precision medicine have been identified globally. But the one started off by the ADA and the ESD is sort of unique because it represented the fundamental initial steps toward definition of a global framework for precision medicine in diabetes. This collaborative effort has already generated the first document simultaneously published in Diabetes Care and Diabetology. The report explores the current state of precision medicine for diabetes with special reference to diagnosis, treatment, prevention, and prognosis, and it identifies barriers and opportunities in pursuing precision diabetes medicine. We are much indebted to the steering committee of this ADA-ESD working group for the quality of their work and for organizing this new meeting. In the next couple of days, more will be discussed, with emphasis on type 1 and type 2 diabetes, gestational and monogenic diabetes, and historic and future perspective of precision medicine. The new data that are going to be presented and the critical discussion that I'm sure will follow up will allow identifying new challenges and new opportunities, and will bring more items into the agenda for the development of a true precision diabetes medicine. It is the final goal of this ADA ESD initiative on precision diabetes medicine to favor the development of a new taxonomy of the disease, supporting a more precise diagnosis and a real personalized therapy and prevention with a timely treatment initiation and timely treatment modification. Hundreds of years has gone by since the revolutionary discovery of insulin. That discovery has set the precedent not simply for what has been a therapy that saved the life of millions of persons with diabetes, but also the mindset that should drive innovation in medicine and in diabetes. Now it is the time for diabetes not just to rely on treatment approaches to be used in as many as possible subjects, but rather we must collect all information that may generate the individual blueprint for every person with diabetes. The EASD is proud to be partnered with the ADA on what may be the new and next step into a new era of diabetes medicine. I would like to wish 3 days of a fruitful discussion, and I look forward to what will be another important report and another step forward from this group. Thank you very much and have a great work.
Thank you very much, Stefano, for those remarks. I think also showing a similar enthusiasm to Tracy. It's great to have the support of the EASD and the ADA, and indeed other organizations as we forge ahead with this initiative.